Thank you, Madison, and it's great to be with everyone. So much of what I'm going to share with you is, I think, pretty simple, but I might kind of raise my voice a few times because the clinical implications of these simple concepts of testing and supplementation literally will change lives. Certainly mental health, mental illness, and dementia. And that's what we need to talk about. And I'm going to talk a little fast because I want to make sure I leave time for questions. And in our program in Psychiatry Redefined, I try to help people understand that there's so many concepts to functional medicine, functional psychiatry. And I use these terms, you are what you eat. Absolutely. We understand the role of diet, whether it's a healthy diet or ultra-processed foods. And we understand the role of nutritional deficiencies. And we also look at what our body's able to digest and absorb. And certainly things like celiac disease, one of the most overlooked contributors to mental illness that I've seen many, many years, all related to some of the things we're talking about. So when we talk about mental health and mental illness and where functional medicine fits in, we have to go back to the basics, sometimes sixth grade science class, and talk about what really essential means. And essential nutrients means our body can't make them, and you need to obtain them from the diet, right? So we have essential fats, vitamins and minerals and amino acids you have to get from your diet. And they work as either precursor molecules like your tryptophan from your turkey might be a precursor to serotonin, and then cofactors, vitamin and minerals where it helps the body does its thing. So here's just one example of a nutritional cofactor. I think this has both vitamin D and folate. We'll talk about folate later. But if you have your turkey sandwich or your egg or any kind of protein that has tryptophan in it, it's not going to get to make serotonin, the neurotransmitter, without these cofactors. And for serotonin, we need both vitamin D, the rate-limiting step, and we need folate, among others. So it's just really important to understand nutritional cofactors in metabolism. And we're going to chat today about this relatively simple blood test. We're here to learn about testing and supplements called homocysteine. So it's called a non-proteinogenic amino acid, right? It's made from another essential amino acid, methionine, but the body really doesn't know what to do with it, and it just creates havoc. So we make it, we got to get rid of it. And there are a couple different ways to metabolize homocysteine, what's called methylation using B vitamins, which is the focus of here, or something called transsulfuration. In the brain, it's really just this methylation pathway, and that's what we're going to talk about, okay? So homocysteine, we need to get rid of it. And how do we do that? This is simple. We need vitamins B6, B12, and folate, B9, to metabolize homocysteine. It can't get more simple, right? And why do we want to get rid of homocysteine or keep it low? Because it is a significant risk factor. Documented, I'll go through some of these studies, over 25, 30 years to be associated with dementia, Alzheimer's, schizophrenia, depression, Parkinson's, cardiovascular disease, neural tube defects, and depression, probably among others. So we have this very simple, inexpensive blood test that is a risk factor for some of the most significant neurodegenerative illnesses of our time. And this test is not routinely done by my psychiatric colleagues anywhere. Clearly, many of you and our functional medicine docs might be looking at homocysteine, but it is not standard practice. And that's why I'm raising my voice and asking everyone to help me, because it has to be. We'll talk about it, and again, how to treat it. So I just use this as an example to throw around that most prestigious journal in American medicine, New England Journal of Medicine, in 2002. Lead article, Plasma Homocysteine as a Risk Factor for Dementia and Alzheimer's. What are we in now? In 2025? That means 23 years ago in the New England Journal of Medicine. Nothing happened. I was a psychiatrist, never discussed in 25 years of training. So this simple blood test, a strong independent risk factor in our most prestigious medical journal. Okay, so we can let that go if you want. And then here they acknowledge in 202, guess what? You can get rid of it with taking B vitamins. So let's move on. 16 years later, Alzheimer's Disease Journal. Now we have an international group of experts looking at all the studies, new and old, and same conclusion. Elevated plasma homocysteine, a modifiable risk factor for cognitive decline, dementia, and Alzheimer's. Did that change clinical practice? Not for many, certainly not for my mental health colleagues. So the literature is clear that homocysteine elevation results in cognitive impairment, and pretty clear how to lower homocysteine. Okay, so that's the easy part in the 2018 study, which was interesting. If you look at homocysteine levels, you'll see, normal is kind of under 9, 10, slightly different for men and women. But here, in this 2018 meta-analysis of all the old studies, that even mild elevations, here greater than 11, is associated with age-related cognitive decline. As a psychiatrist, I'm interested in understanding and helping my patients with anxiety and depression. And we have research on depression. Elevated homocysteine associated with increased rates of depression for a lifetime and episodes. In my clinical career, thousands of patients over 30 years looking at homocysteine levels, I can share with you that it is not just what the literature has clearly established, which is dementia and depression. Let's just think about this for a minute before we go on how to treat it. Depression is the leading cause of disability worldwide. Leading cause of disability. So we're talking about heart disease and cancer and kidney disease. And they do these studies. How do you measure disability? It's pretty interesting because they look at many, many factors, everything from pain to disruption in quality of life, and every other chronic illness can be debilitating. But globally, depression, I think we're up to 400 million globally. Depression was related to single greatest disability. It's huge. And we all understand what's going on in this country. I think it's 40 million. And the amount of antidepressants and current treatment models, which we know are kind of not what we would hope. Outcomes are just poor with our current treatment model. So I'm glad everyone's here listening to alternatives. But what I started on is the literature is quite clear: homocysteine, dementia, Alzheimer's, and depression. In my clinical experience and training thousands of doctors over the years, we've found elevated homocysteine associated with every other major psychiatric illness. And we'll go through a little of that when we talk about specifically the B vitamins, because there's lots of causes of elevated homocysteine. But in a clinical practice, if you look for homocysteine, you will be treating anxiety, depression, dementia, OCD, and a whole host, even psychosis. Okay, we're going to focus on the B vitamins, which is B6, B12, and folate. It is that simple. So B is for better brains. Let's talk about the B vitamins. Every biological pathway, I mentioned at the beginning, cofactors. Nothing happens without these cofactors. We can't metabolize energy without B vitamins. We can't make neurotransmitters without B vitamins. They work synergistically, although we tend to test and treat, and there are variations in genetics as to both the need, and for all of these B vitamins, there is a nutraceutical effect, which is a nutrient having a pharmacological effect, and deficiencies. So B12. B12 is probably the most common cause of elevated homocysteine, but not the only cause. But we'll start here. It is important because it is the epitome of what a functional clinician should be thinking of, and that term is called biochemical individuality. There's no one symptom of B12 deficiency. Maybe in a textbook, it might say fatigue is a symptom of B12 deficiency. But in the clinical world, we've seen everything from significant neurological changes that look like MS. So you can have muscle weakness and clumsiness. You can have depression and fatigue. But we've also seen mania and psychosis and irritability and a whole host of problems. There's no one set of symptoms for any micronutrient deficiency. But B12, again, most common cause of elevated homocysteine. But I've used the term many times, one of the single greatest tragedies of modern medicine, because we don't understand how to assess and treat B12. We, as in my traditional medical colleagues. I can't tell you how much of my career has been treating B12 deficiency after a psychiatrist, a family doc, someone else said, your B12 level is normal. And these are some of the lines that it's within the normal range. Your B12 level might be low, but your methylmalonic acid is normal, so you can't be deficient. You don't have anemia. And these are all the kinds of concerns that we see. But we know B12, again, is related to, one, bringing down homocysteine, but independently related to anxiety, and most of the research is depression, large 14,000 individuals. And here's a teenage study looking at, again, B vitamins and homocysteine with a negative correlation between depression severity and B12 low. So there's some correlation, elevated homocysteine and depression in teens, and here in the elderly. Low B12, elevated homocysteine, British Journal of Psychiatry. So the research is extensive. I just picked a few, but what do we need to think? These are kind of at-risk populations. We worry about our vegan, vegetarian colleagues who might not have adequate B12, but you have to test. The elderly, certainly we worry about any kind of GI disturbance. And again, any kind of chronic neurological signs, you need to think B12 deficiency. I think one of the most important things I can share with you that has to be addressed more carefully is that this is, I think, a Quest lab slip. If you see there, that normal range here, can you see that 200 to 1100? Some lab companies might even say 150 to 1200. There are variations, but I have said for many, many years, and no one has proved me wrong yet, nobody feels well with a B12 level under 500. And you see here in the yellow highlighted, Quest actually changed a number of years back and said, well, some people between 200 and 400 might have neuropsychiatric symptoms. Okay, but nobody reads that, and other labs don't even put it down. And the PCP sees an individual with a B12 level of 300, and they're saying it is normal. You don't have B12 deficiency. I'm sharing with you from extensive clinical experience and training doctors around the globe for many, many years. This is absolutely false. You feel better if your B12 levels are over 500. Particularly relevant if someone is, eating a meat and other sources of B12 and their levels are below 500. And again, B12 deficiency, we'll go over, could be the cause of elevated homocysteine, but homocysteine might be normal and you still might be low in B12. So we look at just a B12, a serum level. We want to look at anemia, blood count, methylmalonic acid, something we learned in medical school, is always elevated if B12 is low. And I will share with you that is also wrong. I don't understand the biochemistry, but I've treated many, many patients that had normal or low methylmalonic acid and very low B12 and felt better with B12 supplementation. B12 deficiency clinically is associated with anything to do with the CNS. Again, early symptoms that look like MS, check B12, and we've seen every major psychiatric or psychological symptom. The most common being depression and anxiety. But I've seen adolescents present mania and psychosis with very, very low B12. So the last thing I want to say about B12 is that blood levels don't always correlate with levels in the cerebral spinal fluid. So even if a blood level is normal, even if it's 500, and someone is developing early cognitive decline, it is completely appropriate to treat with B12 because we have studies going back many years because they did spinal taps on patients and their blood levels were okay, but the levels in the CFS were very low. So it's important that we distinguish between supplementation for B12. It always should be sublingual. There's so many products out there that are liquids or capsules. I just don't understand that, because if someone is having adequate B12 in their diet and they're not absorbing it, you want to make sure you give them sublingual capsule. For sublingual capsule, I use anywhere between 2,000 and 5,000 micrograms, either once or twice a day if I'm trying to replete it. And often, injections, IM or sub-Q, 2 to 3 times a week initially, and then going to monthly can be incredibly helpful. Again, I use methylcobalamin if I can for sublingual, but for injections, I often use hydroxycobalamin. Sometimes methylcobalamin can be stimulating. Everyone asks for, what supplements. This is just one example that I've used. It's a pure melt, so it's a lozenge, so it's absorbed under your tongue. We're going to talk about folate in a minute, but each lozenge has the 1,000 micrograms, so you can use up to 2 to 5 a day. Okay, B12, again, serum doesn't always reflect CSF. Jonathan Wright, one of my mentors, used to say you could drink a bathtub full of B12 without having a side effect. Rarely are there problems. So empirically, regardless of their levels, if you have early cognitive decline, fatigue, or depression, giving B12 is completely safe. And again, think of blood levels over 500. Folate is, one of our methyl donors. Right? So to get rid of homocysteine, folate is going to be a cofactor in handing the methyl group to make homocysteine methionine, a harmless amino acid. So it's kind of important. And there are different kinds of folate. What many of us think about when we use the term folic acid, we have to remember that doesn't exist in nature. Folic acid is a synthetic vitamin that was made in a lab in the 1940s. For most of us, we convert it to folate and L-methylfolate, the active form that crosses the blood-brain barrier. But it is not natural. It is a synthetic supplement. It is L-methylfolate that crosses the blood-brain barrier and associated with neurotransmitter synthesis and breaking down homocysteine in the brain. So I did a paper on folate when I was in medical school. So some of this literature goes back a long time. We've known low folate associated with not only higher incidence of depression, a very, very dramatic poor response to antidepressants. If you had low folate, you didn't respond to the SSRIs as well, and higher relapse rates. This literature has been known for many, many years and repeated. And then we started adding folate to medications. And so we know folate supplementation can enhance the effect of the medication. We'll talk about dosages in a minute. There are lots of reasons people are deficient in folate. Inflammation being a common factor, obesity, aging, digestion. There are many medications, particularly the medicines that we use in psychiatry that interfere with folate metabolism. A lot of the mood stabilizers that we use in psychiatry affect folate metabolism. We can add alcoholism here, but genetics is really what I want to talk about because it's significant. It's hugely significant for our patients struggling with mental illness that aren't getting better with our traditional model, which is medications and therapy. I've worked in a hospital level of care for 30 years, and maybe 25 of these years testing for MTHFR variants. And the vast majority of patients ending up in a psychiatric hospital, ending up treatment resistant, have a variation of this folate gene. So there are a couple different aspects. We look at the one MTHFR variant and the CT. And we think of T as for trouble. And the CT, the 1T is actually, common, almost the majority. Each T variant decreases efficacy of converting folate in your diet, whether it's folic acid from a pill or enriched food or folate from your spinach, to L-methylfolate, the source that your brain needs. So if you think of each T variant is decreasing the efficiency, the efficacy of that conversion, 35%. That's pretty significant if you had two Ts. So you have a 70% decreased efficacy of converting folate in your diet to L-methylfolate for support in synthesizing neurotransmitters or breaking down homocysteine. Again, genetics is just our vulnerability, right? It's just loading the gun. But so someone could live to 100 with this TT variant and never need folate other than their dietary intake. But if we add in someone that has a T variant or TT, if we add in inflammation, that could be due to stress or obesity. If we add in trauma, if we add in a nutritional deficiency of B12 or any host of other stressors, then that TT becomes a vulnerability that we significantly have found related to outcomes of anxiety and depression. And for our discussion, elevations of homocysteine. So the literature is pretty interesting because it addresses a lot of major psychiatric illnesses. The only one that I haven't seen that I stuck on is OCD. But we have a literature for addiction, which I didn't put here. But depression, schizophrenia, bipolar, and ADHD, there are higher variants of this MTHFR. But again, it's not integrated into our treatment model. It's certainly not taught in our training programs. And it is not something that our clinicians, our unenlightened clinicians, not this group, would be thinking of. I've used the term not testing for MTHFR variants is malpractice in my book. I don't know how I could see a patient without knowing that they're not that 11 or 14% of the population that has a TT variant. And if they're walking into my office with any of these illnesses, it's unlikely they're going to get better without additional folate. I differ from a lot of the community out there that got indoctrinated with these high folate supplements, these medical foods. Deplin was the first one. They came out at 15 milligram pills because they had to be able to charge a lot more than a supplement. So they called it a medical food, which means you needed a prescription. Might cost a couple $100. They did a few studies and it demonstrated, yes, 15 milligrams helped depression and augmented the antidepressants. But over the years, I started seeing more and more anxiety and agitation and side effects to these high doses of folate. One of the things we're all familiar with in terms of folic acid is a concept of neural tube defects. Folic acid, we had the research done probably 25 years before we started recommending it to pregnant women. But either way, folic acid is in every prenatal because we know a small amount, 400 micrograms, prevents neural tube defects. Spina bifida, one of the most significant birth defects in our country that almost eliminated by these prenatal folic acid, the synthetic supplements. So for this 400 micrograms to have such a huge difference in brain development, think about it before you just hand somebody 15 milligrams of folate supplement. So my recommendation again is the low dose folate can be incredibly helpful. I have titrated my way up to 7.5 and 15 occasionally, but you're going to see some anxiety and agitation. So I start low dosages, usually the 400 to 800 micrograms, pure melt I mentioned, or if I need to add, I usually do a couple milligrams. So here's a pure melt. It's 400 in each lozenge. And then I just wanted to talk about a B complex per minute. This is the one I use from Pure B Complex Plus because it has the L-methylfolate, it has the B12, and it has high-dose thiamine. But we'll come back to that in a minute. So let me try to review for a second. We started this discussion talking about homocysteine. It should be tested for on every patient struggling with any mental health issue. If it's elevated, let's just say over 12 for discussion, you want to find out why. I just shared two examples. It could be B12, it could be folate or an MTHFR variant. We didn't have time to discuss B6. It could be a B6 deficiency. It could be all the above, which means oftentimes we use a B complex, particularly that has enough B6 and B12 and folate, because we didn't find one source, but you want to make sure in 60 days that homocysteine level is decreased. So that's why sometimes we use a B complex. There are also formulas like homocysteine formula that just has B6, B12, and folate. I don't recommend those to start. It's fine as an add-on, but if your B12 is 320, you don't want to give a B complex or the homocysteine formulas because it doesn't have enough B12. You want to give that individual high dose B12 injections, whatever you need to normalize that B12. The point here is testing is critical. A simple, inexpensive test covered by every insurance company should be, and Medicare, and I believe Medicaid. And if it's elevated, we try to decrease it. I recommend retesting in 2 months. B6, B12, and folate is usually sufficient. If it is not, in a few months, we might add a supplement called trimethylglycine, right? Adding more methyl groups to make sure homocysteine is decreased. We've seen homocysteine levels in the 50s, 60s, 70s. Severely psychiatrically impaired individuals, they improve when homocysteine gets better. So I know they're can send you the PDF for these. These are my websites. We have all our training programs on Psychiatry Defined, and all my books are on my website, James Greenblatt.
Welcome to Rupa Health, the best place to order, manage, and track results from over 30 different lab companies in one single place for free. It's going to take you under 2 minutes to sign up, and you can order any functional medicine lab for your client in under 30 seconds. Let me show you how it's done. So here's our beautiful interface. I'm typing in the name of my client, selecting the lab that I want to order for them, and hitting send. From there, Rupa and their amazing team handle the rest. They email the client, collect payment, and even offer an interest-free 3-month payment plan. We've also built the world's largest library of information about chronic health conditions, the lab tests that can help you find the root cause, and the evidence-based interventions that you can use to help people heal from them. It's called the Rupa Health Magazine. There, we have in-depth articles about almost any health condition you can imagine. And we give you step-by-step protocols that other clinicians have used to help their clients heal and that are verified by evidence-based sources. You should totally check it out, and it'll transform your practice. And we can't wait to see you. So make sure you sign up today at rupahealth.com.